their last date of exposure. And this is kind of to have them wait out that incubation period and kind of wait and see if they become sick. And this way they're not exposing others in the community or in a healthcare setting in the meantime. Next slide, please. So today we're going to talk about patients and residents and also healthcare workers. So this first set of slides is specific for patients and residents. We covered this slide, I think, the last time that we presented, but I think there's just been a few change noting the criteria for screening, including change in clinical status with no immediate explanation for infection. I think we can move on because it's not the main topic for today. The highlighted squares in yellow are part of this flowchart that we went over in a previous session, but these are the parts of the flowchart that we're going to talk about today, kind of what you do with folks that need to be placed into isolation or quarantine. Next slide, please. You know, this, I'm not sure if the font is just a little large. It looks like it's cutting off at the bottom here. Does it look that way to everyone else too?
It does. It was weird.
Yeah, maybe let's try reformatting it real quick because I want to make sure everyone can see.
Caitlin, can you just read off your slide?
Sure. I want to make sure everyone can see them as well. I have my own deck. Oh, there it is. Oh, that looks great. Thank you so much. Okay. When do we test, isolate, and quarantine patients or residents? So ideally, we would want to test anyone who we're worried about, but to preserve supplies and test kits of PPE, we've listed out some kind of prioritization criteria. Obviously, at the top is symptomatic patients. We're also interested in testing asymptomatic patients in selected situations, especially in kind of communal living situations or long-term care facilities, where it might make sense to cohort people based on their test result. And then also all close contacts should be in 14 days of quarantine after last exposure, kind of no matter what, regardless of the test result. Next slide, please. This is what isolation looks like in a long-term care facility. So we put a patient or a resident as much as possible in a single patient room. If not possible, we try and cohort them and keep them as separate from the other residents as possible, including with a separate bathroom area. They'd be placed under contact and other transmission-based precautions such as droplet or airborne precautions as necessary. Next slide, please. So then, you know, they're under isolation. How do we clear a patient or a resident from isolation? So there's kind of two options right now. There's the test-based strategy or the symptom-based strategy. So they both have merits. Right now on CDC's website, they indicate a slight preference towards the test-based strategy. And so this is a great situation when there are plenty of test kits and the test is reliable with a quick turnaround time, everything like that. Symptom-based strategy we might need to employ when there's a shortage of test kits And I would also argue there are other benefits to the symptom-based strategy, such as it's a little bit simpler, easier to implement, doesn't rely on access to testing, things like this. So I'll walk through both strategies in a little bit more detail in the next slides. So next slide, please. Great, and I apologize for the formatting here, but I think everyone can still mostly see the content. So test-based criteria for residents or patients with symptoms. So there's either a suspected or a confirmed COVID-19 case. We have preferred in red in the upper right-hand corner here. This is in alignment with what CDC has on their website too. They indicate a preference for this test-based criteria. So this depends on resolution of fever without the use of fever-reducing medications and improvement in respiratory symptoms, such as cough, and negative results for the PCR-based test for COVID-19 from at least 2 consecutive NP swabs collected at least 24 hours apart. So it says total of 2 negative specimens. So that's what the test-based criteria looks like and how it's laid out on the CDC website. Next slide, please. If testing is not readily available for whatever reason, or if there are too many cases to make the test-based strategy feasible, or for whatever reason someone might choose to decide to go with a non-test-based strategy, there is the symptom-based strategy or kind of time-based strategy, and this is again for residents or patients with symptoms. So for these people, we would have them remain in isolation until at least 3 days or 72 hours have passed since recovery. We define recovery here as resolution of fever without the use of fever-reducing medication and improvement in respiratory symptoms. And we included at least 21 days have passed since symptoms first appears. So 21 days is probably new to most people here. We've been saying 7 days previously. So for our community contacts, people in the community who aren't in a long-term care facility or aren't necessarily in a high-risk setting, we're releasing people from isolation at 72 hours since recovery and 7 days since onset of symptoms. However, we do recognize that these are kind of high-risk settings, and we really want to have a little bit higher bar for these kinds of settings. So, we put 21 days here. This is kind of what we're toying with. This would be more conservative than CDC's guidance. CDC has kind of from what I've seen, they're changing their guidance frequently, but last I checked was kind of a blanket 7 days since symptom onset. And I'm not sure if anyone was really fully comfortable with that because we want to consider the different patient populations in different settings. So we put 21 days here. I will say it's a little bit open for discussion. So we definitely would seek community and stakeholder input on that moving forward. I'll continue with the rest of the slides though and take questions at the end. Yeah, next slide. Let's keep moving on then. So switching gears a little bit to healthcare workers. So isolation and quarantine of healthcare workers. So for the first bullet point, so if staff are asymptomatic but have had a medium or a high risk exposure, which we'll talk about in a minute, to someone with COVID-19, they must be excluded from work for 14 days since the date of their last exposure. CDC's website, their guidance seems to be shifting on this. They have a new guideline that says if staff are asymptomatic in some scenarios, they may be allowed to work even if they've had a medium or high risk exposure as long as they remain asymptomatic. Here in Hawaii, our epidemiology is a little bit different. We're still kind of in this almost containment type of response where we don't have the level of cases that somewhere like New York is seeing. So as long as it's feasible, we'd love to adhere to this strict 14 days of quarantine after last exposure. That said, we're planning for the future. Who knows what will happen? Every facility is a little bit different. If you're facing a critical staffing shortage and someone has a low risk exposure, they may be allowed to work as long as they remain asymptomatic and wear a face mask at work. And we may have to kind of modify these if the epidemiology in Hawaii changes. And then of course at the bottom there, if anyone develops even mild symptoms, any symptoms at all, GI symptoms, anything, stop all patient care activities, notify us at DOH, leave work, self-isolate, and get tested. Next slide, please. Just highlighting where in the flow chart we are talking about, this yellow box at the bottom that says see risk classification table, which I think we have on the next slide. This is the risk classification table for assessing the risk of healthcare workers with exposure in a healthcare setting to COVID-19. Before I even go into this, I'll note CDC has actually archived this on their website, so they've stopped updating it and they aren't really referring to it anymore. We are probably still going to in Hawaii. You know, we're still at pretty low case count and we still can, it's feasible for us to adhere to this kind of table and risk assessment. So again, I apologize. You know, the name of the game these days is CDC rapidly updating guidance, and us here in Hawaii trying to make sense for our Hawaii epidemiology and what we're seeing locally. So I'll walk through this just briefly, but I think that's the note on the lower left-hand corner where we're trying to get at. If we see a rapid increase in cases or a shift in the epidemiology, you know, this may become a moot point, which is what CDC kind of alludes to on their website. For now, I don't think it is a moot point in Hawaii. These are stratified by if the patient was wearing a face mask or cloth face covering, or if they weren't. And then it's further stratified by what PPE the healthcare provider was wearing. The actions for medium and high risk exposures are the same. It's to exclude from work for 14 days after last exposure. For low risk exposures, so this is just if the healthcare provider was lacking just eye protection or one other piece of PPE, not the mask. Lacking a mask puts you at medium or higher, but eye protection or other PPE puts you at low risk, not no risk, but low risk. And the action is self-monitoring for 14 days after last potential exposure. And what that means is twice daily temperature monitoring. You know, I think we're reaching a point where most of our facilities have implemented universal masking of all healthcare workers and all patient care areas. So I think the vast majority of our exposures are going to be in this low risk category. And on that same note, most of our facilities, if not all, have implemented temperature and symptom screening prior to every shift anyways. So I think we're reaching a point where most of the exposures are in this low risk category, and most of what we're doing is kind of assuming that everyone is at least low risk now anyways. But this is what we refer to when we refer to the healthcare worker risk assessment. And also notably, you know, we're calling 48 hours before symptom onset the whole potentially infectious period of exposure, not simply once symptom onset starts. Next slide, please. So same question for healthcare workers. When can they return to work? Test-based strategy versus symptom-based strategy. Next slide, please. Test-based criteria for those with symptoms, it's the exact same slide we showed before: resolution of symptoms, resolution in respiratory, or improvement in respiratory symptoms, and 2 negative tests collected at least 24 hours apart. Next slide, please. Symptom-based criteria, and again, I don't know what happened with the formatting, but we'll clean these up before we send the slides out or otherwise display them to you guys. But similar to the symptom-based criteria for patients or residents to discontinue isolation, but the non-test-based criteria for work exclusion for healthcare workers in these settings, the first bullet is the same: at least 3 days or 72 hours has passed since recovery, defined as resolution of fever without the use of fever-reducing medications, and improvement in respiratory symptoms. And it's a little hard to see here, but we're saying 14 days since first symptom onset to return to work in a long-term care facility setting. Again, CDC website, they say 7. We'd like to be more conservative here because we're not seeing the widespread transmission that some other jurisdictions are seeing. We think 14 days would be feasible here, and we'd love to err on the side of, I guess, caution and not get our healthcare workers back to work until we're totally sure that they're going to be no longer infectious. Next slide, please, and then I'll talk about this a little bit more. So we know a lot of people are testing positive, but they remain completely asymptomatic. So this is kind of troublesome when the criteria is based on resolution of symptoms. So if there were no symptoms to begin with, what do you do? And we're saying they must stay home from work until 14 days since their positive test. So we hope that this will be a little bit easier to remember because it's 14 days, 14 days. For the asymptomatic individuals, 14 days since the positive test. For the symptomatic individuals on the previous slide, 14 days since illness onset. We say here, no need to retest. We don't have a recommendation for retesting. However, if through whatever channel the healthcare worker does get retested, a negative will not reduce the 14 days here. So the negative, it's kind of irrelevant. A positive will extend it. So for every additional positive test, we will extend the isolation period for an additional 7 days. And this is the same as what we're doing with folks in the community. If they continue to get retested, they continue to test positive, we're adding 7 days to their isolation. This gets thorny. We're dealing with this in real life right now in a few scenarios where people decide to go with a test-based strategy and try to do this kind of test for clearance, and they just keep testing positive for a very long time, even after their fevers resolve or even after their illness resolves. Colleagues across the nation are reporting this too. My colleague in Montana has a healthcare worker who's tested positive 7 weeks in a row now. So that's, quite a long time to be out of work. So it can get a little thorny. We want everyone to be kind of prepared as the epidemiology changes, the burden on our healthcare system changes. We think it makes sense to have a plan to bring people back in, maybe sooner than this if it's no longer feasible to meet this criteria. So we want to think about our priority strategy, and 2 points that we'd like to suggest if you're going to bring people back sooner would be they must be absolutely asymptomatic and prioritize bringing people back who are as close to the end of their 14-day period as possible. Next slide, please. Staff returning to work, we want them in an actual surgical mask, not a cloth mask. Still should wear the N95 and other PPE when caring for a suspected or confirmed COVID patient, and do not care for patients who are particularly immunocompromised. And as usual, what everyone should be doing is self-monitor for symptoms and immediately self-isolate if symptoms return or worsen. Next slide, but I think that was the last one. Oh yeah, other considerations. I think these are just for the facilities to think about, review and revise your sick leave policies to eliminate the incentive to work while sick. And I think I would only add to that, make sure that like a facility or an administrative level, you're really affirming the health and wellness of every single staff prior to every single shift. Not necessarily relying on people to self-isolate themselves once they've been sick. And, I really don't have much to say about the Hotels for Heroes program. Not familiar or affiliated with that program, but I'm not sure if someone else is on who's able to talk to that a little bit more. But I'd love to take questions now. I see one in the chat box already.
By the way, this is Haley Shea. I'm with helping out with the Hotels for Heroes program, so I can answer any questions.
Oh, that's great. Great.
Thank you for being on the line. Yeah, if you could just explain the program and who might be qualifying for it and how you apply or get on board with that. Could you just explain?
Sure. The program actually started on April 6th and it ends on May 3rd. It was made available through the Hawaii Tourism Authority, the Hawaii Visitors and Conventions Bureau, and the Hawaii Lodging and Travel Authority. And what they did is allocated a number of room nights to all the hospitals all the skilled nursing facilities and all the physicians in the state. So when we reached out to inquire how many employees would be interested, we essentially got response of over 36,000 room nights, and we were given 2,500. So the demand was tremendous, and so we had to allocate the room nights among all the major hospitals and skilled nursing facilities. And so what we've been doing is, as time's been going by, if a skilled nursing facility or others are finding that they don't need to use all their room nights, for instance, on the neighbor islands, they've been donating their room nights back so we can give it to other hospitals. It's mainly intended for frontline staff who are treating COVID patients, and they may have elderly or at risk at home, and they just want to be cautious and stay in a hotel. And so that's one group that's been using it. Other groups, if they're traveling to the neighbor islands, Scott Viscovich's group, when they're doing the COVID screens, traveling from neighbor island, we house them as well for nights. But again, you must not be COVID-19 positive. You must not be awaiting a test result. So if you've taken a test to see if you have COVID, you're not eligible to stay in a hotel. When you're in the hotel, you must self-quarantine, self-isolate. So in a sense, you're not supposed to go down to the bar, the restaurant, the pool. And it's only one person in a room. You can't bring family members or other guests into your hotel room. Any questions? That's kind of high-level overview just in terms of the program. We have been able to get more nights. When Maui had its situation, Mufi Hanneman, who's the lead for the program, he was able to acquire more nights, and we were able to give Maui Memorial staff some nights. But it's available to, I guess, each hospital. And if there's interested staff who want to use a night, each hospital has a point of contact, and they can just go through their point of contact or reach out to the program and we'll direct them to the point of contact. But every hospital is participating, probably a third of the skilled nursing facilities. And then now we're starting to reach out to the federally qualified health centers and physicians.
So if there are folks who are not participating or don't have your contact, can you just maybe put in the chat box how they might be able to get on?
Well, right now we don't have any more room nights available. So again, the demand has been so overwhelming. Right now, we have a new group who needs nights. We're just kind of taking away from other areas. We were able to help the Hawaii residency program, but that was only because another facility donated their nights back. But I can enter my information, but I just want everyone to know there are no more nights available.
Okay, thank you. All right, shall we get back to the questions at hand?
Yeah, I see one in the chat box. Please review again strategy for healthcare workers with mild signs and symptoms. Stop work, notify DOH, tested, and then what? Yeah, good question. So healthcare workers with mild signs and symptoms, those are the right first steps. Stop work, notify us, see if they can get tested. I think then it kind of depends on the test result. I think if anyone's pending a test result, they should definitely, of course, stay out of work. If it's positive, then they're a case themselves, and then we'll follow the criteria that we laid out for return to work for COVID-19 cases. If they're negative, this might be a gray area that requires some consideration of the full epidemiological and clinical picture. We're trying to warn everyone to not necessarily act on one negative result. Sometimes if they have a known exposure to COVID and then they're sick, even if they have a negative test, you still might want to take a step back and think about, is there a chance that there was a false negative, and do we really want to kind of bring this person back to work? If there's another plausible diagnosis, if they get tested for flu, something else, that's fine. You can follow your workplace protocols for returning to work after something like that.
Caitlin, this is Nicola Poliona from Kula. I had
Hi,
two
great.
questions. Hi, on the, so we are just working through this morning on people calling out sick with mild symptoms. And we have 2 that we're testing this week. Does Department of Health have the bandwidth for us reporting every single work, call-in sick, mild URI symptom person?
That's a great question, and no, I don't think we do. I don't think we need to know about everyone who's calling in sick, especially with mild illness. I think we want to know about, we keep saying confirmed or suspected COVID-19 cases. Suspected, of course. I don't know if we've put out a great definition, but it would be strong clinical suspicion of COVID-19. And those are the cases we want to know about. We don't need to know about your healthcare workers who are kind of calling in sick for maybe non-COVID related illness or mild illness. As if there's a positive test, that's of course a different story.
So if they, yeah, it does. If they have mild symptoms, URI symptoms, we test them, they're negative. We should keep them out for 7 days, 14 days.
And hey, Caitlin, I was able to join late. Yeah, this question is definitely coming up, and I think for workplaces, it's a balance between, you know, you got to make sure your staff who are safe to work can come to work, but also not wanting to have a misstep where somebody who tested negative initially turns out to have COVID. So I do think the bottom line is if someone is symptomatic, they should be at home. And it kind of has to be assessed with that employee. Obviously, if you have concerns that someone is using that as an excuse, that's something that you would have to work through with your staff. But I think right now everyone's kind of on the side of, if we kind of have to trust each other, and if someone is reporting symptoms, they really shouldn't be coming to work with any acute respiratory symptoms.
Okay, so no symptoms, till symptom resolution.
Yeah, and when you have difficult, I understand there are situations where somebody has underlying asthma or chronic cough, allergies. Those can be difficult situations. And those might be situations where a test can be helpful to rule out. And if you already had a low suspicion and the test is negative, you can feel pretty comfortable, okay, and that person saying, I'm not having any additional, you know, I'm not having the fever or the body aches. This seems pretty much like my allergies. Those are things that you kind of have to work through. And I think we're forced in facilities to get a little more hands-on with those kinds of assessments than we might typically, where you kind of let people tell you if they're sick or not and come in when they're ready to come in. I think your facility administrators and your charge nurse, whoever, may need to be a little more hands-on in the current climate to make sure they understand the reason somebody needs to be out.
Okay, and then I had one more, that since we just had a bunch of patients on isolation here, the extending the isolation time to 21 days for residents. I think we had a pretty low risk exposure here, and we did the isolation for 14 days. We had an asymptomatic healthcare worker who was wearing a cloth mask was the source of our exposure. But people were going nuts being in isolation for 14 days, our residents. We had issues with making sure they were even eating and drinking enough, and we were following their weights really closely because we were concerned about that. So I know everything's a trade-off and we're weighing all the risk and benefits. And it seems like everything is sort of a case-by-case situation.
Well, just to be clear though, the 21 days, and we're sort of floating this because this is not official guidance yet, but we're trying to move towards a time-based strategy that would work. But that would really be for people who have tested positive. That's for a confirmed resident case. So we're not talking about somebody who's on quarantine, you know, on precautions because of a possible exposure.
Okay.
Yeah,
great.
this is for someone who's a confirmed case.
Okay, thank you.
And that would be in lieu of, so if you have a confirmed case and we get to a point where testing them again and again and again is not making sense, this would be an alternative strategy for that known positive person.
Great, thanks.
Yeah.
Looks like we have a question from Dan Saltman, right? Hawaii Learning Groups. Can we talk about the statewide capacity for testing?
Yeah, I wish I knew. Yeah, does anyone have? Yeah, I think it seems to me, and we kind of have indirect knowledge of this just through working with all of you guys. And when you do have scenarios where you need testing, we get feedback on how easy it is to actually access that testing. It seems to be local and variable. So certainly on Maui in the past few weeks, we've had a few weeks or days where testing was not that easily accessible on a particular day in a particular location. I'm still hearing that tests are pretty widely available through the clinical laboratories, but I do think when it comes down to it, it's kind of a week by week or even day by day assessment of that. So it's good for all of the facilities to take stock now and know what your current supplies are. If you needed more supplies in the event that you had a situation, who would you be reaching out to? Who would you be ordering from? What does back order look like? So I think those are good things to be aware of and have your finger on the pulse now.
My understanding is that nursing facilities don't have the tests on hand, and they would call clinical, they'd have to get it from a laboratory.
From one of the laboratories.
In order to do it.
So it is good to open those lines of communication now and ask, if we needed 20, 50, 100 tests tomorrow, where would we get those from? Those are important questions to be asking through the clinical channels. We have some capacity to help with testing at the state laboratory, but when we talk about a whole facility sweep of like 200 patients and 500 staff, that's not immediate capacity that's available at the state lab at the drop of a pin. So all of that would take some planning. So certainly though, for, from our last webinar, if you have strong suspicion, clinical suspicion for a resident in your home or in your facility, those are people that for right now where we're at, we're not talking about doing a whole facility sweep. You have a couple residents you're concerned about, those can definitely be prioritized through the state lab. So if you're having trouble getting those tested commercially, please do give us a call and we can facilitate that.
Any other questions?
No? No?
Okay.
Yes.
There's a part two of this, I guess. Dan Saltman has this something about 20. My understanding is about 40% of these come through the drive-through screens, which would be kind of an untargeted approach. Would we have more positive cases if we had better test targeting?
Yeah, what a great question. We are constantly trying to reassess how to make sure we're testing in the right places. There has been this huge push for testing across the state, but I think it's happened in a fairly disorganized way when it happens commercially because, clinical, the clinical availability of testing is based on payer status and other things sometimes, or where you are at, how easy it is for you to get to one of the pop-up sites, a lot of factors. So that is definitely a question that the state, that we at DOH continue to look at closely. We have a sentinel surveillance program. We actually have run into challenges there because so few people now actually meet the influenza-like illness criteria. I think people are staying home and we're actually seeing a big drop in respiratory disease in general and influenza-like illness in particular. And because influenza-like illness criteria relies on fever, COVID, as we now know, many people don't initially present with fever. So we are, in some ways, back to the drawing board to strengthen our surveillance systems and try to get a better population-based sample of that. So that's an ongoing project.
Hi, this is Dan. Just a follow-up question on that was is it possible that is there a way to look at the I was thinking about the death rate numbers that seem impressively low for Hawaii, and I was wondering if there's been another look at that would be comparing the so my wonder was, were people misclassifying deaths as not being COVID related just because that's the way it is. And that maybe, have you done a comparison of the sort of baseline death rates for this time of year or this kind of circumstances and seeing if there's been any excess deaths beyond what you would anticipate as a pre-existing baseline?
Right. So one of the tools that we use for that is based on our existing influenza surveillance system. So we do have a weekly pneumonia and influenza report. And one of the measures we track in there is mortality due to pneumonia and influenza. Those two things are coded together on the death certificate, and so we look at them sort of as a combined measure. So we have been tracking that throughout this time period, and we have not seen any significant change from baseline in our pneumonia and influenza mortality in the state. So that's one indicator that at least is reassuring that we haven't been missing a bunch of deaths from COVID. And we also have good relationships with the medical examiner offices and the coroners on the neighbor islands. So we definitely do get notified when they've had suspect cases. So I do think they're looking. We've tested a number of them, most of which have been negative, and the ones that have been positive, I think you've heard about on the news and through our reporting. So we feel fairly good about our ability to detect any change in deaths that would be COVID related, but it is something that always requires additional vigilance too. We're working with our vital statistics department to make sure we're doing adequate trainings on death certificate completion for physicians. And I think that's going to be something that would be great to actually add as a webinar topic in this series.
Great. We have a great question from Malcolm Haruno. Do you want to go ahead and ask your question?
I can read it and take a stab. So, what criteria would you use to assess a recovered COVID positive patient being transferred from an acute care hospital setting to a long-term care setting in light of the non-test-based /new/current 21-day quarantine from last symptoms guideline? So it's a good question, and I'm sure this patient transfer topic is a hot topic. The question of when and where a patient should be transferred, really should be based on the level of care that the patient requires. And then an appropriate setting, if they don't require hospitalization and they're able to be in more of a long-term care setting, we want to be able to get them there appropriately. However, if they are still based on our criteria, supposed to be on isolation or transmission-based precautions, we want to make sure they're in a long-term care setting that's able to adhere to those transmission-based precautions. I think plenty of our long-term care facilities are able to do that, and if they're not, I hope that they're preparing to be able to accept patients that require these transmission-based precautions. So patients are still able to transfer, I think, while they even require these precautions. It's just we would want to be involved in that process and make sure that we're able to work with both facilities and that the transfer goes smoothly and everyone's comfortable with implementing the appropriate precautions until we're able to discontinue those precautions. I don't know if Dr. Kemble has anything additional to add on that.
No, I think that's accurate, and the main point being that the location of the patient, the acuity of the patient shouldn't be determined by the testing. So if they're ready for discharge and they aren't cleared yet, ideally we'd like that patient to be able to be transferred to the level of care that's appropriate for them, and that clearance can still happen in either setting. So if they're cleared in the hospital and they're removed from transmission-based precautions, that's great. But if they're not ready for that yet and that clearance process has not been completed, they should still be able to transfer, and we want facilities to feel prepared to still care for that patient and manage the clearance process on their end, whether that ends up being done through a test-based strategy or a time-based strategy.
Hi, this is Nicole again. I'm sorry to talk so much, but I think saying that long-term care facilities should be prepared to take COVID positive patients while they're still in their isolation period is asking a lot. That patient should be in a private room on transfer and use the full PPE, of course. and many of us cannot accommodate patients in private rooms. So I think that would have to be a baseline expectation that the patient would go into a private room, and that doesn't occur in a lot of long-term care nursing facilities.
Yeah, and I do think that is a prerequisite to transferring a positive patient, that you do have a private room and adequate PPE and staffing to accommodate that. I think that this is one of those things that's going to be a little bit of a push and shove kind of situation, especially since we are in a low prevalence state. If we did see a situation where we had a lot more cases, it becomes more a matter of cohorting. So you might end up having multiple residents who were positive being cohorted together in one part of your facility. So I think the key is planning for those different scenarios. The main thing we want to avoid is backup of low acuity patients in hospitals at a time when maybe they're seeing a surge in high acuity patients. We don't want to have a backup of patients in a place that's not the best level of care for them when those resources might be really needed for high acuity patients. So I think it's that's why these conversations are really good for that planning process. So you can think about how will we manage that if we get to a point where the hospitals really do need to get those patients discharged to an appropriate level of care.
I think, Kula being a critical access hospital, we were prepared for that. And our surge plan required us to have a dedicated unit to accept these COVID patients, initially privately housed and then cohorting. But the unit has to be separate from the rest of our long-term care population. It has to be staffing dedicated, can close the door to that unit and really keep them separated. And that's the only way we're going to protect the rest of the long-term care, the 85 other patients I have in my building. And judging by the experience of nursing facilities on the mainland, especially in places where they did have a high prevalence of COVID, it's a recipe for disaster to bring them in any other way than to have a completely separate unit. So I think all those things need to be considered. And lucky for us, our acute care hospitals have not had a surge. They haven't been tight for beds. On Maui, I think we're at maybe 70% capacity right now of our regular beds, not including the beds at Maui Memorial that they could flex up to. So the pressure, we can respond to pressure when it's necessary, but it's not there right now.
That's a great point. I would love to hear from other facilities and how they're thinking about this. And especially any who have sort of a maybe within a health system relationship to acute care, how you guys are talking about that handoff or transition.
Okay, we have another question. A resident in long-term care tests positive in a shared room. Would the roommate not tested yet have to be kept in the same room, then be tested rather than moving the roommate?
Katie,
Sure. Sure. So the roommate would be a close contact then of a positive case, unfortunately, due to the shared room. So the roommate would be placed under transmission-based precautions as well. So this would be kind of that quarantine that we were talking about in the beginning. So they've had a known exposure to a positive case. They're not yet sick, but they're in this 14-day kind of quarantine monitoring period, I guess, while they wait out that maximum 14-day incubation period. Regarding moving rooms, I think that's a great question. I don't know if Dr. Campbell has input on.
Yeah, I guess my thought on that is these are the sorts of scenarios that we are actually doing some one-on-one consultation with facilities when they come up, because they're tough decisions and it does depend on your bed availability and your staffing. I think the ideal situation is going to be that you are able to separate the two and have them both in isolation rooms separately. Some facilities don't have that option, so depending on the scenario, we'll discuss an option of keeping them together and instituting droplet for both. If possible, if the patient who is positive is able to tolerate being masked, that's a situation where masking the patient might make sense. But if not, it also depends on how long the window of exposure has already been. So if the patient's been symptomatic for several days with the roommate there, you kind of think, well, the exposure may have already happened. So there's the ideal world, and then there's the real world, and I think that's where we want to be a resource, and maybe this group can be a resource to help people work through those tricky scenarios to make the best possible decision.
Okay, any other questions while we have these guys here? Okay.
Okay,
Oh,
I'm sorry, I never run out of questions. Let's see, I was wondering what you thought about early pulse ox monitoring, early and frequent O2 monitoring of people who are infected to identify when they are really sick before they may be symptomatic of being really sick. That seems to be one of the unique characteristics of this virus.
Mm-hmm. I would ask for those in facilities, what proportion of your residents typically are getting pulse ox monitoring? Any answers to that? My speculation would be, I worry you'd get a lot of false positive alarms that way. So I guess you'd have to think through how. I see you're shaking your head, Dent.
It'd have to
Yeah,
be
yeah,
a
yeah.
trend. That's right. You
Yeah,
might, an
yeah,
isolated number is not the issue,
yeah,
but
yeah.
a downward trend that you see 3 times in a row kind of thing in their oxygen saturation, that would be the positive result. Not a single test. That's right. That would be
Yeah.
a red herring that way.
Yeah, I mean, that's an intriguing idea. It probably would have to be kind of piloted to see. There's probably certain patient populations that might work pretty well for, and others where they might be always taking off the pulse ox and it wouldn't give you all that much good information. So that's interesting. If anyone tries that out and feels like that's a good strategy, that would be a great to share back with this group.
okay, Nicole had another question.
That's a related question. That's
Yeah.
an excellent question. It's the same idea. How do you know how sick they are before you need to transfer them to an acute facility?
Mm-hmm. I think that assessment should be the same as for other diseases and situations, in that if you're seeing, dropping stats, it's the same kind of triggers that would generally trigger a transfer out to acute care. We will, in our webinar, we're planning to do a public health grand rounds webinar with Dr. Park again next week on Wednesday. So we will be reviewing some of the clinical characteristics of the cases to date, including hospitalized cases, and that may help to fill out some of the clinical picture. But I think it's mostly what we've been seeing reported in the other literature, that fever can be a good sign but is not sensitive, and then shortness of breath and cough are really 2 of the harbingers of COVID-19 in terms of symptoms. We're also noticing body aches and chills, maybe not a documented fever, but the body aches are a very commonly cited symptom, and sore throat is reasonably common. It's still going to be less than 30% of our cases, but that can also be an early sign. So some of the symptom screens that you're doing on a unit basis can also be good ways to kind of pick up some of those early signals in terms of whether a problem is going on. But in terms of what requires a higher acuity of care, I think that's going to be similar to other decision making for flu and similar illnesses.
Yeah, I just want to comment that, we're talking about pretty frail older adults. And that's why we need to have the goals of care conversation early on, not wait until they start getting really sick. And we're going to we'll have a bigger discussion about that next week as well. But I just want to underline that thought, because sometimes if they crash, they're going to crash quickly. You might not have that much time to discuss it. We have lots of other tough questions here about insisting on acute care hospitals to test before transferring back to assisted living. There's a lot of strong feelings about this in our long-term care community. And not sure we want to open that box.
Well, the one thing I'd
minutes
say about,
before we close.
I want to be a little bit cautionary on insisting on a test for transfer, both for the reasons I cited before, but even if beds aren't the issue with hinging it on the test is that we don't still really understand what that positive PCR means for the infectiousness of that patient. So I totally get basing it on whether you have the bed availability, the staffing availability, and the private room to take that patient. But to insist they test negative before coming to your facility, I think is a slippery slope, and it will lead to a lot of other challenges. And maybe I'll just leave it at that for now.
Okay. Anyway, I'm just going to throw out there also that, a lot of facilities don't have, as well-meaning as they are, and as much as they try to prepare, they actually may not have the capacity to take patients who are COVID positive and needing rehab and needing to recover, and that perhaps the state needs to actually figure out another solution for that. But that's, I think, in development and in discussion, and not ready for prime time yet. Okay, so looks like we always have lots of discussions, and I bet we can keep going on because I see nobody has actually fallen off the participant list. But we do have to sign off. So please come back and join us again next week. We will talk about staffing strategies, and of course we'll repeat some of the previous issues as these things all overlap a little bit. And you'll have an opportunity to ask questions again on Friday. Okay? Take care, everybody. Stay safe.
Thank you.
Thank you all. Bye.